Good afternoon all, good afternoon ma'am. So myself Harshini and this is Gopika. So we are here to present the case. So Mrs. X, a 23-year-old pregnant Gravida from Anand, homemaker of the patient, studying up to 10th standard, belonging to the lower middle class according to modified Kumarì scale, with the last menstrual period of 11/4/2024 and the expected date of delivery 16/1/2025 and the period of gestation is 33 weeks, 2 days and it's a good case. So she presented to the OPD with the chief complaints of history of amenorrhea since 9 months. Patient has come for regular antenatal checkup. History of present pregnancy. First trimester, the patient was conceived naturally. Pregnancy was confirmed by urinary pregnancy test following 10 days of missed periods. History of nausea and vomiting present. No history of hyperemesis, urinary tract infection, fever with rashes, spotting, bleeding per vagina. Pre-pregnancy weight is 37 kgs. Blood pressure was checked and found to be normal as sent by the patient. Blood investigation and dating scan was not done. Tablet folic acid intake present. No history of intake of antibiotics, antiemetics, antacids and progesterone. No history of radiation exposure. Second trimester, progress in enlargement of the abdomen was noted by the patient. First trimester symptoms like nausea and vomiting reduced. Quickening was felt at 5th month. No history of bleeding per vagina. No history of headache, blurry of vision, epigastric pain and pedal edema. No history of pain abdomen. Blood pressure and weight was checked and was told normal to the patient. Oral glucose tolerance test was done and found to be normal. Anomaly scan was not done. Iron and calcium tablets were taken. First course of TD was taken. Third trimester, progressive distension of the abdomen was seen. Fetal movements are well perceived. Daily fetal movement count was done. No history of pain abdomen, bleeding or leaking per vagina. Blood pressure was normal. Weight was 49 kgs. Fetal heart sounds were heard using handheld Doppler. Growth scan was done at 32 weeks of gestation. Non-stress test was done. Routine blood investigation was done and the patient's hemoglobin was found to be 8.8 gram per deciliter, for which she was admitted for anemia correction. 4 doses of iron sucrose was given. Calcium tablets were taken. Menstrual history, she had...
Can we stop a minute? What is meant by antenatal care?
Antenatal care is the care which is given to the mother to support pregnancy and other events happening after the pregnancy. Postpartum also will give care.
When will you start an antenatal care? Should normal. The first visit.
Immediately after confirmation.
Can you consider this a normal routine care? That is it enough? The blood investigation. What are things? If the patient comes to you, what are things you should?
Confirmation of pregnancy by urinary pregnancy test.
Why there is an antenatal visit?
For assessing risk, ma'am, if she has any risk.
Okay, it is very good. There is risk assessment.
Risk factors.
Then second,
correct gestational age calculation.
Maternity care, isn't it?
Provide care to the mother.
Third, that is you have
medical history and surgical history. Any medical disorders.
Isn't it?
Yes, ma'am.
Yeah. Then third thing.
Medical history, surgical history, if you want to get from that, you can get for calculating gestational age of the patient.
Okay. So the risk scoring is very important, isn't it? Yes. First itself. Some patients can be high risk from the beginning itself. But there are certain factors which are very particular in that particular pregnancy which can make either the mother or the mother can become high risk by means of her problem or with the problem with the baby, isn't it? Tell some examples.
If mother has anemia, even fetus also.
She is a high risk candidate, isn't it?
Yes.
Whether it was prior she was anemic, we doesn't know.
No.
She is only 23-year-old.
23-year-old primary
gravida. Then
she belongs to lower socioeconomic.
That is not her this thing, isn't it? But what are the routine investigation you want to have in the first visit?
Hemoglobin, urine, blood grouping can be done, RH incompatibility, HIV, screen for syphilis, hepatitis B.
Yeah.
Then maybe unemployed test. Dating scan. Dating scan.
already in the morning itself you have, the madam has a nice this thing, isn't it? But something you have missed.
Oral glucose tolerance.
Yeah, oral glucose tolerance, if you want you can have, isn't it? But hemoglobin was also not. It was nothing was done in that.
For this patient, hemoglobin was not checked during the first analysis.
Then coming to the BP was normal, isn't it?
Yes,
In the second trimester?
Second trimester. BP was
Only the BP. He was not given. How much iron is required in the, or what are the supplements you give? In the first trimester, in the second trimester wise?
So first trimester we used to give only folic acid. From second trimester we will give 60 milligram of elemental iron and 400 microgram of
That is
folic
for the
acid.
prevention only, isn't it?
Prevention. And therapeutic.
When you look at the hemoglobin is in trimester fashion, then only you have to find out whether the patient, at the beginning of pregnancy itself, whether she is anemic. To begin with, she is
first trimester, already she has nausea or vomiting, so you cannot supplement iron.
Okay, that is routine. You are not supposed to give any iron over the that is nausea and vomiting. You are not supposed to give any iron in the first trimester, isn't it? But from the second trimester onwards, you have to prophylactically you have to give.
Prophylactically once daily, therapeutically thrice daily.
Yeah, that is the therapeutic. Then only you have to assess what is the hemoglobin in the first trimester itself. Okay.
Menstrual history, menarche at 12 years. It's a regular cycle for 28 days, slow for 4 days, heavy eating, using 5 to 6 pads per day, fully slow, no severe particular growth or dysmenorrhea. Marital history, she was married at the age of 22 years, non-consensual marriage, no history of use of contraception. Past history, no history of diabetes mellitus, hypertension, epilepsy, bronchial asthma, tuberculosis, heart disease, thyroid and renal disorders. Deworming was not done. No history of prolonged bleeding after injury. No history of any surgery done. No history of blood transfusion. Family history, no history of hypertension, diabetes mellitus and epilepsy in family. No history of bleeding disorders in the family. There are 4 members of the family. No history of thyroid disorders. No history of congenital defects in the family. Personal history, she consumes a mixed diet, normal appetite and adequate sleep, normal bowel and bladder habits, no history of constipation and bleeding piles, no history of drug allergy, no history of alcohol and smoking. Diet history, the total calories required during pregnancy is 2,500 kilocalories. This patient has intake only 1,586 kilocalories, that is she is deficient by 940 kilocalories.
Almost 1,000 kilocalories is definitely is deficient, isn't it?
Protein is 32.4 grams.
How much is the protein requirement?
1 gram, 1.1 gram per kg.
Non-pregnant status it is?
1 gram per
You
kg.
have to have an additional 0.1.
She is not taking iron foods like green leafy vegetables, liver, ragi, and is not adequate proteins. This is calculated by 24-hour dietary recall method.
So the other foodstuffs which raise the hemoglobin, that is
Green leafy vegetables like spinach, drumstick leaves, liver, heme iron, non-heme iron.
What are the heme iron?
Animal sources like liver, red meat, pork, poultry, pork, all these things. Non-heme is green leafy vegetables like spinach, drumstick leaves, then dates, fruits like watermelon, ragi, these are iron rich.
So what is the difference between a heme iron and a non-heme?
Heme iron is readily absorbed. It increases the absorption of non-heme ions.
The factors which prevents an absorption is mainly from the
Non-heme iron, phytates, phosphates, all these things will decrease iron absorption.
Then what? Only the food or something else? You said there is nausea, vomiting, isn't it? That will reduce. Anything else?
If there is hyperemesis gravidarum,
There is nausea and vomiting. Is there any other factor which reduces the absorption from the gut?
Acid and fasting state increase absorption. So A-chloride will decrease iron absorption.
and calcium decreases iron absorption.
Other factors?
Other factors, coffee intake.
Tea, coffee, calcium. So you should take it either before or 2 hours after.
Pregnancy situation, it increases iron absorption or decreases the iron absorption? That means it is demand is more, isn't it? So you think the absorption is more or
Absorption is more.
So when the demand is more, she requires more and she takes more. The system is also taking much more, isn't it? It's okay.
General examination, the consent was taken, the patient was examined in a well-lit room with adequate privacy. The patient is oriented to time, place and person and she is cooperative. The patient was moderately built and nourished. Pre-pregnancy weight was 37 kg as said by the patient. Current pregnancy weight is 49 kg. Weight gain is 12 kg. Her height is 150 cm. BMI is found to be 16.4 kg per meter square. The pallor present, no interest, sinuses, clubbing, lymphadenopathy and pedal edema.
So where will you look for pallor?
Lower palpebral conjunctiva, in the nail bud and in the palmar crease, in the tip of the tongue and in the vaginal mucosa, in rare cases.
Then sinuses?
Sinuses, central sinuses and peripheral sinuses.
What's the significance of finding out whether she is cyanotic or not?
Then hemoglobin concentration is reduced, oxygen carrying capacity is reduced and we can assess whether she has any congenital cardiac disease.
Also, is there any heart disease first or even severe anemia can also have
Sinuses.
It is a long-standing thing, isn't it? It is not. Okay. Then jaundice.
Jaundice, hemolytic anemia, we can assess.
Hemolytic anemia.
Hereditary spirocytosis, G6PD deficiency and thalassemia, sickle cell anemia.
Okay. Then coming to lymphadenopathy, what is the significance?
We can assess an infection like tuberculosis, madam.
Second.
Secondary lymphomatous and Hodgkin's. Malignancies can be ruled out, ma'am. Leukemias.
Then what is the other? Edema. Is that
Edema.
But Mado also said there is edema.
They can be physiological or pathological.
But the edema, how can you say there is physiological edema?
It subsided after 8 hours of sleep, ma'am.
What are due to mainly?
Mainly due to the compression, increased plasma.
Yeah.
Due to the compression of iliac veins, ma'am. The gravity uterus compresses on iliac
Apart
veins.
from that, you have a hemoglobin which is reduced. Along
Plasma volume increases than 40 to 50% the plasma volume increases than the red cell count is 20 to 30%. So hemodilation occurs and physiological anemia occurs.
physiological. Okay. The hyperproteinemia is another situation where it causes an increase in the edema. Where will you look for edema?
In the median, above the median malleolus and then in the shin also we can do shin of labia.
How many seconds you have to press?
30 seconds.
Then you can say that there is
Pitting on
the causes of non-pitting.
Phylloidiasis.
Any other?
Then DDT.
Mixed edema, have you heard?
Yes, ma'am. It's hypothyroidism condition.
This also reduces a mixed edema, isn't it? That is thyroid disease. Then hepatitis splenomegaly, it is very rare to find it because the
Abdomen is distant.
It will not be possible, isn't it?
Yes.
Okay.
Systemic examination, cardiovascular system, S1, S2 curve, no murmurs, respiratory system, normal vesicular breath sounds, no airway sounds.
Yes, VBS, can you expect some
Yes, ma'am.
changes or alterations?
Yes, ma'am. Systolic, heaving systolic murmur
Can
can
you look for that?
in the IOTA,
Can have flow murmurs.
flow murmurs,
Because it is hyperdynamic.
hyperdynamic circulation. CNS, no focal neurology,
Respiratory.
Technically,
With anemia, respiratory. Where will you look for? Lung veins, isn't it?
basic groups.
What is it due to? If that is there, what does it indicate?
Hypoxic condition, oxygen is
Less
oxygen saturation.
So, that is basal fine
Crepitations can be had.
What it is due to?
Pulmonary
anemia.
cardiac failure can happen and pulmonary edema can happen.
It means that she is in failure, isn't
Yes,
it?
ma'am.
Okay.
Then thyroid and breast examination.
Yes.
No.
Anemia plus some CNS. Can you
C-
go with something? Some other associated, not only iron with something else.
Demyelinating disease B12 deficiency.
Which is 12.
B12
Subacute. Combined
Combination.
this condition, which what is it?
B12.
B12 deficiency. Yes. Okay. Thyroid.
Thyroid and breast examinations were normal. Then vitals, pulse rate is 100 beats per minute. It is regular rhythm, normal volume, no abnormal character, and no radiofemoral delay. Blood pressure was 110/70 milliliter mercury. Temperature is equilibrium. Respiratory rate is 16 breaths per minute. Other examination, hair is in normal texture, nails are normal, mouth coilonelia and platymelia.
Begin with, it may be a lustrous.
Lustrous.
Even hair can also be a lustrous.
Sparse hair can happen. Then
Platymelia, or you can get
coilonelia, spoon shape means.
profound, you can get
Coilonelia.
then mouth.
Glossitis, stomatitis.
There can be discoloration.
Yes, ma'am.
What other?
In
Your tongue.
tongue also, weak feet tongue, vitamin B12 deficiency, anemia, we can megaloblastic, we can get a smooth tongue.
With the loss of papilla and all, isn't it?
Yes, ma'am. Next. Obstetric examination, consent was taken, patient was examined in a well-room with good exposure and adequate privacy. The patient was examined in a supine position with the knees and thighs flexed. Inspection, abdomen was longitudinally distended. All quadrants moves equally with the respiration. Umbilicus is central and flat. Flanks not full. Linea nigra is seen. Striatum is not present. No scars, sinus, dilated veins. Hernia orifices are intact. Palpation, no local rise in temperature and tenderness. Abdominal width was found to be 81 cm and it corresponds to the gestational age. Symphysial fundal height is 33 cm and it corresponds to gestational age. Abdominal ribs, according to Leopold's manual, fundal rib broad, soft, irregular, non-allowable mass felt of the fundus. Lateral rib, there is multiple knob-like structures on the right side that suggest of limbs. Uniform resistance on the left side suggests of spinal swell. First pelvic rib, there is a hard allowable mass felt on the lower part of the uterus. Second pelvic rib was not done, and auscultation, fetal heart rate is heard on the left spinal-umbilical line, and the heart rate was found to be 126 beats per minute. Summary, a 23-year-old Mrs. X who is primarily at 33 weeks of gestation with the last menstrual period on 11/4/2024 and expected date of delivery on 16/1/2025, who is on examination present with a single live fetus in cephalic presentation with a good fetal heart rate. She is a case of anemia complicating pregnancy who was admitted for further evaluation and management of anemia. And my provisional diagnosis is moderate anemia complicating pregnancy, most probably due to nutritional deficiency.
I think this may be the first diagnosis.
Yes.
What is meant by anemia? Can you define anemia?
Anemia is a decrease in oxygen carrying capacity of the blood due to both qualitative and the quantitative decrease in hemoglobin and the red blood cell.
How much should be there?
It should be at least, according to the WHO, if it is less than 11 gram per deciliter in the first trimester and the third trimester, the women is said to be anemic.
So, how can you grade the anemia?
See,
What are the different types of anemia?
nutrition anemia, hemolytic anemia,
According to the severity, how will it be?
mild to moderate severe, very severe, 10 to 10.9
From
from
condition. So it may be the 10 to 10.9
9 gram per deciliter. Mild anemia.
What is meant by the physiology anemia?
That is due to increase in the plasma volume than the red cell volume, hemodilation occurs, which causes anemia.
Mild up to 10.
10.
In the moderate,
7 to 10 gram per deciliter.
you said you belong to your
Moderate anemia because she had 8.8 gram per deciliter.
and less than that, you call it as
Severe anemia, less than 4. Very severe is 4. 7 is severe.
severe anemia.
Congestive cardiac failure.
What are the symptoms you can occur in an anemic patient?
Fatigue, weakness, breathlessness.
Aggravated, isn't it? Normal pregnancy plus an aggravated. But you won't get any too much tiredness because of physiological pregnancy, isn't it? But when the patient is, definitely when she is in failure, other features also come in. How will you manage? What are the causes of anemia?
It can be due to decreased absorption, increased demand,
Is having
nutritional anemia.
say that it is nutritional.
Nutritional means she is not taking adequate diet, and she is deficient nearly 1000 kilocalories, and she is not taking iron-rich food like green leafy vegetables, ragi, and so on. And she is in first trimester and second trimester, she is not taking adequate iron tablets also in second trimester.
We can also take folic acid. So.
Yes, okay.
And she is having a menstrual history is also, she is having increased bleeding.
So during menstruation, how will you confirm your this thing?
Investigation.
You want to come to a diagnosis, isn't it?
Investigation.
What is the type of anemia, isn't it?
By the peripheral smear.
What are the investigations?
Blood group, hemoglobin and hematocrit. Then peripheral smear.
Hemoglobin plus something.
Hematocrit.
What is the relation between the hemoglobin and the hematocrit? If you have 10 gram percentage, how much will be the hematocrit?
It is reduced
10 into 3.
3,
So it's almost
30.
So like that you can. The second thing,
Peripheral smear.
suddenly what are the other these things?
Red cell
There is
release.
thirdly red cell releases.
So the second will be
Peripheral smear.
what are these?
Microcytic hypochromic infection.
That is, what is that?
You
What
take
stain you do the
Leishman stain.
Leishman stain. What stain will you put for the peripheral smear?
Leishman stain.
It is the Leishman, isn't it? So how will you classify the type of
Microcytic hypochromic.
if you have a nutrition anemia, what are the usual type you get?
Microcytic
If it is
hypochromic.
iron deficiency, what are the
Iron deficiency, it is microcytic hypochromic, which salute to mechanism.
normal cells numbers?
5 normal cells, 7.5 RBC size, 7.5 microns.
In this peripheral smear, you can see
Small cells.
okay. Smaller cells. That is why it is called the
Microcytes.
hypochromic means
Central parallel.
yeah, usually it is a central parallel. Any other thing you can make out by
Teardrop cells, other cells will be present.
no.
And in case of hemolytic anemia, we can see the blood cells, schistocytes.
Okay. In the megaloblastic type,
Hypersegmented neutrophils, macrocytic
hypersegmented more than 5, isn't it?
5.
It is more than 5 segments usually. There can be associated, in that case you can have associated thrombocytopenia. Sometimes this white cells also will be reduced, isn't it? And rarely you can have abnormal cells like leukemia also you can make out by. And you can have the spherocytes.
Hereditary spherocytes.
The red cells will be of globula, isn't it? Then any other parasite you can see in the
Malaria.
also you can find out by
Inclusion bodies.
yeah, there are so many. So that is hemoglobin, hematocrit. Then comes your
Indices.
indices. What is the indices? Index.
MCV, MCHC, MCH, and zinc protoporphyrin. And finally, we will go to marrow iron
It's
studies.
the first one which go out of abnormality. First out of
MCHC.
MC.
MCV is the first to reduce.
But you can rely on that. Why? Because most of the iron deficiency, it may not be seen,
Yes, ma'am.
isn't it? One.
So we are going to MCHC.
Yeah, MCHC, which is irrespective of that, you can find out whether it is there or not. Then, if what are the stages of iron deficiency?
First is ferritic iron stores will be depleted.
Is it source? Stores.
Stores is depleted. Then is tissue iron deficiency. Third stage is iron deficiency anemia.
Frank iron deficiency.
Frank iron deficiency.
When the stores are depleted, your marker will be
Ferritin, serum ferritin levels.
what is the normal ferritin level?
Less than 6.
Less than 12 microgram per liter is iron deficiency.
What is the normal ferritin 25. How much? Okay, if it is less than, how much you call it as?
Less than 12 microgram per liter.
There is
iron
depleted.
Depleted.
It is stores are depleted. Any other investigation you need?
Total iron binding capacity is
That is
increased.
the one which
Increased more than
the iron binding capacity, because there is no. So it is the iron binding capacity.
more than 350 microgram per deciliter.
Anything else? Any other investigation?
Transferring results.
Any other routine investigation? If patient is anemic, you can get so many others.
Yeah, and
Urine routine.
because she's prone for infections, ma'am.
You can have an associated urinary infection. You have to go for a urine culture sometimes. And what is the management? What is the management? For your patient, what will you do? She's moderate anemia.
Moderate anemia and parenteral iron therapy is started.
What is the significance of parenteral iron?
You will get an increased RBC, that is hemoglobin is increased within 3 days.
One important point regarding parenteral iron. And how will you consider whether it is oral iron or parenteral or blood? What are the factors? If it is remote from term and it is moderate anemia, you can, of course, you get time to correct it by your oral. But oral over the other will be your surety fitness.
Third trimester.
So she is having trimester. But because it is nutrition anemia, she may not be taking, and along with that you have to give the other factors also. What is the indication for blood transfusion?
When severe anemia in any trimester, you can give blood transfusion.
One second.
If she is not tolerable to
Bleeding. Okay.
cardiac failure,
What's the balance?
You should cut short in the second stage of before labor, cross-match